So what I've done is just to try and put some headline issues into the presentation. The substance is in the report itself, but maybe just to give some context to the proposals, because one can always look at suggestions for health reform as kind of a set of blue sky abstract notions. The reality is that health systems reform is difficult, and you usually operate from the system that exists, that has evolved over time. And the main thrust of the framework that has been presented is really the architecture of a health system that would make sense for South Africa going forward. And it is an enabling framework. It looks at basically establishing the framework within which everybody will participate and operate. It's not a top-down version, and I'll go into that more. It's not one where the system tries to determine what every element does from the top. It's a system that establishes a framework that allows people from below to operate and make effective decisions, whether people are in the public or the private sector. So the proposal is a universal health access proposal. And or coverage, and maybe it's not in the presentation, but it's in the document. The term universal health coverage and access are two particular terms that are important. Universal health coverage has been used in particular by the WHO, and that implies both access and financial risk protection are combined as part of an overall policy framework, and that's entirely valid. Our emphasis on access is because in South Africa is a constitutional requirement. So Section 27 of the Constitution talks about access to healthcare. So this is an enabling framework that talks about allowing for universal access. So the first issue, just to kind of give an overall guide, is the report basically looks at a strategic focus on reform that can guarantee universal access to healthcare for South Africans and the region. By that it means that regional players who come to South Africa will have also be captured within the system. The report and associated process is a response to sort of continued weaknesses in the South African health system resulting from stewardship failures over the past 20 years. So the context is that, I mean, effectively what's happened is because of the NHI proposals from about 2007, there's been no reform in South Africa of any form in the private or the public system of any substance. And this has had a negative effect on both systems, as well as the way the overall system articulates with each other. So there have been many missed opportunities for actually making sure that this system could evolve productively. So the concerns, right to be upfront, is that, one could say, well, this is an alternative to NHI. The problem that we have is that the National Health Act raises at least three basic concerns. The first is that the proposals are not in harmony with the current system. It basically deletes the existing system and creates a third one. So these are, and as a consequence, they're actually talking about a system that is not in harmony, but something completely different. And that is a very radical change, which lowers the possibility of implementation. Second, the NHI proposals, both the NHI Act and those yet to be implemented, are generally recognized as lacking both feasibility and any possibility of improving health access. I think that this is a basic challenge, because there's the possibility that the NHI Act and the NHI framework could offer the opportunity for improvement in the functioning of the health system. But the problem, maybe if I just frame it slightly differently, because it wants to delete two existing systems and create a third, it actually allows the whole health system, the two pre-existing parts of our health system, to languish on the assumption that this third system will emerge out of the wreckage. So the problem is that it is lacking in feasibility, and that creates a difficulty, particularly if no other reform is going to happen until this reform is in place. And basically, because of this process, no reforms of any substance have been implemented since 2004. So the proposed reform framework works from a number of assumptions, which I think are important. The one is an unavoidable financial reality in health systems. An effective system of universal coverage in South Africa and in pretty much most developing countries in the world cannot be financed exclusively by general taxes. They can't, in the South African context, we can't basically provide the universal coverage right to everybody in South Africa just using the revenue that's available to government. This is largely because you reach a level of a ceiling as to how much tax you can raise. And whatever you can raise within the state is best prioritized for people who can't actually afford to pay for their own healthcare. So in essence, this means that the institutional design of a health system, if one is being realistic, has to rely on both tax funding and what I call the contributory system, which is basically in South Africa, it is our system of regulated medical schemes. So a contributory system is where you make a contribution to an insurance vehicle for the purposes of coverage. So the non-contributory system, the tax-funded system, is for people who basically would not be able to afford to contribute on their own. So we will always have to have a mix of these two systems to have coverage. But it's important that that these systems are designed in order to achieve this objective. So it's important to note that this doesn't just happen naturally. You've actually got to make, you've got to establish the institutional framework that makes the contributory system and the tax finance system work in harmony. It won't happen by accident. But we will not have enough revenue for the overall health system if we don't combine the two. So the problem with the NHI proposals is they've assumed that they can provide all the coverage through a tax-funded system, which essentially just cancels that as an option. So it's also recognized, and it should be understood in these proposals, that a tax-financed and contributory system work differently. They don't have the same mechanisms, but their ultimate objectives are the same in terms of coverage, but they do operate differently. So the way you regulate and govern them has features which are dedicated to the different kind of system you're looking at. So given this, the government stewardship requires the development of interventions that recognize these differences while at the same time aligning them with overarching system goals. So they might have different ways of operating in the way that the German system operates differently to the NHS, but they both operate with very similar goals. So you've got to keep the goals consistent, but ensure that you understand the engineering requirements of the two different systems. So those are the unavoidable realities. Guiding principles in the proposed framework is derived from this, and that is that basically you want to, because you're going to always be dealing with a multitude of purchases within the environment. This includes provincial health departments, district health authorities, medical schemes. You've got to have a coherent separation of functions. So the NHI proposals propose that everything gets consolidated into a single organization. That means purchasing and pooling functions, basically an insurance and redistributive function, are all encapsulated in one rather simplistic notion, a single organization. In this proposal, in order for the system to work, in order to be able to get this combination of a tax-funded system and a regulated contributory system to work together, you have to decouple the pooling requirements. That means risk pooling and income pooling from purchasing. That is the way in which people buy the healthcare at the end of the day. So in order to achieve accountability and efficiency, you have to decouple these two. These are two different objectives, policy objectives. So you can achieve the pooling functions and the redistributive functions through a mechanism that is separated from the purchasing functions. If you try and combine the two, you essentially create a massive inefficiency potential in the system. So separating them out allows you to focus on the equity objectives with distinct subsidy frameworks and introduce purchasing arrangements through all the complexity that's required at that level of the system. And in public and private systems, there's always going to be a multitude of potential purchasing arrangements that you want to evolve within the framework that is established. You're not going to dictate what they are from above, but you're going to create a framework that allows them to operate efficiently. And that can only be done if you separate these functions. In terms of equity and scalability, the issue is that you implement an equitable resource distribution framework while also enabling the incremental expansion of the coverage of services. So note that this, I would argue, just pointing out the NHI difficulty, is that it's not very scalable because it's a one-size-fits-all option. It's very hard to create a scalable version of it, because its endpoint presumes no medical schemes, no provinces. But how do you scale that up? How do you incrementally implement that? I can't conceptualize it. But with this framework where you separate pooling from purchasing, it's all scalable, and it allows for different parts of the system to be able to grow in accordance with fiscal affordability as well as with the design of systems. So there's a three-pronged strategy that's proposed in the report. So the first is the separation of pooling from purchasing. This requires that there's an equitable resource allocation outcomes which rely on fair pooling systems, which are most logically situated and executed at the national level of the health system. So these pooling systems are akin to an insurance mechanism and a system of income-based transfers. It's vastly simpler to establish resource allocation mechanisms than it is to buy health services at the end of the day. So by separating them out, creating a logical framework for the fair distribution of resources, you separate out the complexity of purchasing from the resource allocation mechanism. So in essence, if somebody said, oh, well, these proposals are somehow different to NHI because NHI wants to introduce equity and you don't, the reality is this is effectively the same level of pooling that you would get in the NHI, except that you're introducing it, except that you're separating it from the purchasing function. Whatever the policy determination is for redistributive transfers is done through a structure of pooling that is separated from purchasing. Number two of the strategy is to optimize the performance of the free public health services. So this is the focus on government services. So within this framework of the separation, it basically retains the logic of the provincial health departments running health services. And obviously there's a big problem there. But the way in which these problems are dealt with is through the introduction of governance changes, as well as the establishment of new structures at the provincial level and the sub-provincial level. So this is the strengthening basically the governance frameworks that will ensure that there is quality of care delivered at that level of the system. And this involves three important features. That's hospital and district authority autonomy. That means that they have decision space, substantial decision-making capacity at their level. At the moment, the provincial departments are very hierarchical. Hospitals themselves have a lot of functions which have been moved out of their direct control. And then, at the same time, a number of delegations have been given to hospitals that have allowed many of them to issue corrupt tenders. And so the issue of localized supervision becomes important, because if you create strong delegations, you create autonomy, there's the risk of corruption unless you have localized supervision. That means supervisory boards at the level of hospitals and at the level of district authorities. This is the approach around the world for public services and functions, and it allows for an immediacy of supervision. And the further estimate, the third one, which is quite critical, is in establishing those supervisory structures, there's a removal of interference from the executive of government in appointments, procurement, and operational decisions. And this is obviously a fundamental departure from the NHI framework, which preserves all of these conflicts of interest, which have basically decimated the provincial departments, our regulators, etc. Then the third element is to optimize the performance of the contributory system, the medical schemes, the paid-for system. And this involves establishing a sustainable contributory health insurance framework for income-earning households. So the idea here is that basically these people are paying taxes which fund the free public services, but they're also paying for their own healthcare. And so there's a strong redistributive element in the overall system, as there is now. But there are weaknesses in our current framework, but not necessarily in the income redistribution aspects. So this involves establishing a sustainable framework. That means that you need to have contributory systems that supplement the maximum levels of coverage attainable finance from general taxes alone. So it complements, it basically adds to the funds that are available to the tax system. And this system basically requires a regulatory framework to ensure that it is sustainable. So the report outlines the details of what that regulatory framework should involve. A large part of it comes from previous committees of inquiry, as well as the most recent health market inquiry. So this basically encompasses the broad framework. I'm just going to run through quickly compare the current situation in South Africa with what we're calling the UHAC proposals and the NHI proposals to see where they differ on key sort of aspects of the overall system. So if we've got the current health system, so if we look at governance, we've got the governance structures, the supervisory structures are influenced by political appointments, which result in weak leadership structures. The UHAC proposals decentralize governance with independent supervisory boards for hospitals and district authorities. The NHI proposals centralize governance under the NHI fund with political appointments into all key leadership positions. It also allows for all of the supervisory problems that exist in public hospitals to continue. So there would be still political appointments even into public hospitals. So nothing really changes from the status quo. In terms of primary care, our system is currently fragmented, inefficient, with long wait times, stockouts, etc. The UHAC proposals suggest that there are autonomous district health authorities established to ensure localized accountability and improve primary care services. So this is a whole new tier of the service. It's built out of what exists. There's building in a layer of supervision and adding to it the sort of decentralized effect, the decentralizing effects of autonomy. So that means that the people in charge of that system are able to carry out all the functions to manage that system effectively and properly. But what's very important is that the localized supervision that comes from the decentralized governance framework ensures that the leadership at that level is much stronger than it is today. The NHI proposals, the whole framework, the primary care system is fragmented. It's very, very confusing in the Act. It's effectively splits functions between the provinces certainly in an interim period between national government and the provincial government. It's very unclear who's actually in charge of what. There's no clear supervisory framework in terms of ensuring that whatever goals are set for primary care are actually going to be carried out. It seems that there has been a focus on buying care and not worrying about the overall supervision of the primary care system, which is what you have to do. You have to have a system that allows for a holistic supervision of it, not just you assuming that because you're buying something that you're creating sort of coherence. Hospital services, they're overcrowded, poorly equipped in the public sector. But the idea is that to establish autonomous hospitals with revenue retention, better governance frameworks that allow for public-private integration. So currently, it would be very difficult for a medical scheme to contract with Groote Hospital because the decision-making is too centralized. Autonomous hospitals are in a position to enter into agreements, but they will also be entering into agreements with their provinces. They will be entering into agreements with medical schemes, and they will have the flexibility to adapt to both the public and private environments. In the NHI proposals, it retains centralized control. They do talk about hospital autonomy, but they don't really clarify it. They talk about partial autonomy. There's no clarity as to what specifically is proposed and what overriding framework is proposed, and it retains all the conflicts of interest that we have today. In terms of the health workforce, the report talks about the need for a strategic, at this point in time, we have no strategic planning and execution framework, which results in unemployed doctors, unemployed pharmacists. That's largely the framework. Now, government has worked on this in the past, have just never implemented anything coherent at the national level. So this proposes that governance reform for workforce planning, training, and financing are introduced. The detail, it suggests in the report that there's a process to establish that, but there's actually been a substantial amount of work done to establish the governance framework for workforce planning and execution. It requires information systems to be collated. It requires that there is a planning framework that is established for strategic planning, that there's a consultation framework with all the health professionals, that there's a subsidy framework in place to support the execution of the whole strategic plan, which would encompass everything up to the end of community service. But the whole strategic planning framework also needs to deal with the fact that you don't want to enroll more people than you can absorb. So all of that was actually planned before, hasn't been done, and the report basically says it must be done. At this point, the NHI proposals don't really say anything. Critical care services, we've got a situation in South Africa where we basically have a bifurcated critical care service. We don't have any framework that has been established for 30 years dealing with this and how to actually ensure that everybody's going to be treated equally in the case of critical care. But it takes a system to do it. You can't just say we do it overnight. You've got to design it. So there's it proposes in the report that there's a national framework for universal critical care access, integrating public and private systems of financing and provision. It doesn't specify the detail. It just says, because there are proposals for this, but they require that everybody is engaged in dealing with this and resolving it, because it's not straightforward. But there's no focus in government on this. So this requires that there's focus on this and that this problem is solved. At this point, the NHI proposal just presumed that it'll buy everything and somehow all these problems will go away. That's completely unsatisfactory. There's no clear framework provided for critical care services. Equity and access, this is polarized between public free but underfunded and private costly services. That's the current status quo. The UHAC proposals suggest the equity would be through a system of properly designed subsidies and improved governance to prioritize low-income groups. So this is largely a focus on the pooling systems and the resource allocation mechanisms that would be central. And they are appropriate to be central. So there are specific proposals that suggest that there's an agency that would focus on doing the technical aspects of this work so that it is not politicized. NHI proposals just aims for universal access but fails to provide a feasible pathway. In terms of the funding mechanisms, we currently have a general mix of taxes and private medical schemes. The UHAC proposals retain that, but basically combine the two. And so there's a tax-funded free service for the poor and contributory insurance for higher income groups. NHI proposals place the entire burden on the tax system. Private sector role operates independently with no strategic integration into a system of universal health coverage. That's a big problem. Government basically just doesn't have any kind of proposal or vision at this point. And under the NHI proposals, it's just marginalized under a centralized NHI structure. So the UHAC proposals suggest that there's strategic integration into a universal health coverage model through regulation of the private sector achieved through strategic subsidies, mandatory benefits, open enrollment, community rating, mandatory participation, risk equalization, and social reinsurance. All of those proposals are actually contained in various reports, the most recent one being the Health Market Inquiry. The role of provincial government currently is responsible for health services, but hindered by corruption, inefficiency, and weak capacity. The NHI diminishes the provincial role, largely eliminated with most of the authority centralized under the NHI fund. Under the UHAC proposals, provinces retain authority, but with improved governance frameworks and autonomy for facilities, increasing responsiveness to local communities. So the whole issue is that the provinces aren't left the way they are now. What is really required is that there is an institutional redesign of the governance and accountability frameworks, what is centralized, what is decentralized, and the establishment of an appropriate system of authorities and autonomous facilities. So just to clarify, pooling mechanisms in the kind of, for those that aren't really used to the terminology, risk equalization, social reinsurance. Risk equalization in the medical schemes, this is the contributory system. It's a mechanism that in risk equalization is a mechanism that ensures inter-scheme transfers. That's transfer from one scheme to another to eliminate differences in the demographics and health status between medical schemes, based on a policy-determined mandatory package of comprehensive services. This is how you design risk equalization mechanisms. What it does is it removes inter-scheme competition on health status and incentivizes competition on the cost and quality of coverage. So it changes the focus, the emphasis of what medical schemes focus on. Social reinsurance. What is it? It's mandatory premiums are paid to a publicly administered secondary insurer to pool coverage for designated low frequency and high cost claims. What does it do? It protects small entry-level risk pools, thereby lowering barriers to market entry for insurers. So basically what this does is it prevents excessive consolidation in the environment, but allows also that you don't have schemes going bankrupt because they have one or two bad claims. This allows for relatively small risk pools to enter into the system and survive. And that is actually quite important to keep the system vibrant. And then just on the last sort of features, equity and pooling. The current system is constrained and inefficient income and risk pooling. So there's no real systems, no real strategy behind what's done. NHI just centralizes everything and assumes that solves all problems. In the UHAC proposals, it separates pooling and purchasing and achieves equity through targeted income and risk-adjusted cross-subsidies. The essential benefit regimes, the public sector provides basic care now, and there are PMBs for medical schemes. There's no broad strategy in government at this point. NHI proposes a sort of a centralized process of committees to determine minimum benefits, but it doesn't actually, because it doesn't believe there will be a medical scheme system, doesn't really understand that you have to have a different focus on medical scheme mandatory benefits from public sector mandatory benefits, and public sector mandatory benefits require a different kind of development, which hasn't been done to date. So in essence, in the UHAC proposals, it says there must be a unified essential benefit packages for public and private systems aligned with financial sustainability determined through a well-governed, independent, inclusive process. So basically, this has to be a focus. This has to be no universal coverage system ever ignores the development and maintenance of essential benefit regimes. That is a key focus. In private insurance environments, essential benefits won't be covered unless in some way they are mandated. But to establish what is mandated needs to go through a process of proper non-political, apolitical decision-making. Free services at point of service. In the current system, it's available in the public sector, but is undermined by poor service quality and accessibility issues. With the private sector accessing prescribed minimum benefits, there are lots of issues around how private sector prescribed minimum benefits are both regulated at this point in time and designed and maintained. The NHI proposals just assumed everything will be free at point of service, financed from general taxes. The UHAC proposal suggests there would be free services for income-compromised households with improved governance and service quality, with mandatory medical scheme benefits covered without co-payment. So the idea would be that when it's mandatory in private sector, potentially these benefits are not subject to co-payments, and that requires a careful design. That is on the basis that you can determine whether or not these benefits these are genuinely mandatory minimum benefits, and make and also allow medical schemes to be able to manage that risk as well, which is not necessarily the case at present. Cost control. Currently, there's no oversight of either public or private sector in the current system. In the NHI proposals, it just assumes this problem is solved because there's one purchaser and everything will be efficiently purchased. That's not valid. Monopoly purchases don't necessarily bring down costs. ESCOM is a case in point. UHAC proposals, risk equalization, social reinsurance, multilateral tariff negotiations, standard benefit packages, all control costs and perverse incentives to overservice. This is part of a framework that has to make sure that the incentives to manage costs are internalized within the system through the key structures that are introduced. Implementation feasibility. The public sector at the moment allows for incremental changes, but there's no strategic vision. NHI proposals are not really, they lack feasibility in alignment with the existing system. They're not scalable. It's very difficult to know how you phase anything in. In terms of the UHAC proposals, they're all scalable and pragmatic reforms aligned with fiscal constraints and the capabilities of the state and the health system. There's no need to raise new taxes to fund this. It's broadly speaking establishing institutional frameworks. In terms of accountability, the current health system is weak with high corruption levels in public sector governance. And one can add that there are also significant weaknesses in the private sector as well. In the case of NHI, it's weak with centralized accountability far from the served communities under the NHI fund with the existing politicized approach retained. Both the current and the NHI proposals are a recipe for corruption, because the people who are running it today, if they were all squeaky clean within 5 to 6 years with the amount of money involved, all the clean guys would be out of the system and only dirty guys would be in it. It's a system designed for knaves to take over from the knights. UHAC proposals require independent supervisory structures to depoliticize healthcare management in all key aspects of the system. That includes regulators, but it also includes provincial administrations, district authorities, etc., which are quite critical. I'm not going to go into this in any detail, but this is a figure from the report as well, but it just shows how it all kind of connects to each other, that there is a revenue sources here, which part of the revenue is goes to medical schemes. There's the possibility of a public default scheme, publicly administered. By public, it is not state-sponsored, but publicly sponsored. Nothing state in this framework. The public nature just means that there's a statutory framework that underpins aspects of its public nature, no political appointments into it. And the resource allocation or pooling system involves potentially a universal unconditional subsidy to everybody, as well as in the medical scheme system, a supplement of risk equalization, social reinsurance, the purchasing frameworks at the provincial health administrations and medical schemes, and your providers, public and private. Public and private providers in this system would be able to service all parts of the system, the provincial governments as well as medical schemes, if this is done coherently.